what we'll discuss today is problem cards of growth and development. Okay, so let us look at the first problem card. So let us read it once. So Mitali, a 22-year-old second gravida with 8 weeks of gestation, came to Anganwadi center with her 5-month-old daughter Usha. Usha's birth weight was 2.75 kg on 19th March last year. Subsequent weights of the child at different ages were, see, at 3 months it was 4 kg. At 4 months it was again 4 kg. And at 5 months it is 4.2 kg. So you can be asked to plot the weights of this particular child on the growth chart and give your comments and then some other questions as well. So how these growth and development problem cards will begin will always be with the growth charts. So it's very essential that you know how these growth charts were developed and what all growth charts are there. Can you quickly tell me what all growth charts are there for children that you need to know of? There is a weight for age, height for age and weight for height separately for girls and boys, isn't it? Okay. So let's go ahead and look at this. So you know, before this we were having some old growth charts which were developed only based on the children of the West. Now after that in 1994, the World Health Assembly passed a motion which said that you cannot give interpretations on children across the globe on the findings of only one part of the world, because statures are different, feeding patterns, nutritional patterns are different, problems, social problems are different, infections are different. So that's why the Multicentre growth reference study was taken from 1997 to 2003. Okay. This study was conducted to develop growth standards which were internationally acceptable and applicable across the globe, right? So as they say, the study establishes the breastfed infant as the normative model for growth and development. That means the growth charts in this study were built upon based on healthy breastfed infants, not based on healthy, formula fed infants or healthy cow milk fed infants. No, an infant in their first 6 months of life should receive breast milk and breast milk alone. So these growth reference standards were built on the model of breastfed infants. That is very, very important. Okay. Going ahead, so the goal was to describe the growth of healthy children. As I said, it was conducted between 1997 to 2003. It included 6 nations. Okay. India was one of them. So Brazil, Ghana, India, Norway, Oman, USA. You can see that all of the continents have got their representation, right? So what it did a longitudinal follow-up study up to 2 years. So for birth to 2 years, it did a longitudinal follow-up study of those children. And between 18 months and 6 years, what it did was, it did a cross-sectional study of the children. So you could not follow them up for that long a period. So that's why for 2 years it was a longitudinal follow-up and for the rest of the children it was a cross-sectional. Okay. So 8,440 healthy breastfed children and infants were included in this study. What was the criteria based on which children were included? So there should not be any environmental constraints on growth and morbidity. That means no economic problem, no infections, no morbidities. Okay. Next, absence of maternal smoking. We know maternal smoking adversely affects fetal outcomes. So no maternal smoking during the period of pregnancy. Next, adherence on MGRS feeding standards. So there were feeding recommendations as to how a baby should be ideally fed in terms of breastfeeding up to 6 months and then initiation and maintenance of complementary feeding from 6 months onwards. Okay. So adherence to that was maintained. And fourth is only children originating from a single term birth. So preterms were excluded and twins, triplets were excluded, because we know that in twin it can so happen that one baby might be low birth weight or both babies might be low birth weight. So single term pregnancies were included in this study. So the inclusion criteria is very, very important. You might think that, okay, what if this, what if that? but they took into factor all of these things while developing these growth charts. So what they did, in the initial weeks, the mother and newborn were screened at birth and with home visits at weeks 1, 2, 4 and 6. Okay. So in the immediate postpartum period, weekly visits were done. After that, they were doing monthly home visits from 2 months to 12 months, okay, throughout the first year. Then in the second year, they did follow-up visits every 2 months, okay. A total of 21 intensive home visits were conducted per child to develop these growth reference standards, okay. So let us quickly look at what are the growth reference standards. As we said, the first one is length or height for age for girls. When you are asked what is this, you will say that you begin from here. This is the WHO child growth standards, length or height for age for girls, birth to 5 years, Z score. That is the entire answer. This is the WHO growth reference standards, WHO child growth reference standards, length or height for age for girls from birth to 5 years using Z scores. That is what this chart is. This is not just a WHO growth chart. Okay. So you might be given this at a spotter also. Ensure that you are writing what this chart is properly. Okay. The gender, mentioning the gender is important. Mentioning the age group is important, and mentioning whether this is a Z score or a percentile, that is also important, right? And mentioning that this is a WHO growth chart is also important, because there are different growth charts as we know, right? So this is the one for girls, the same one for boys. Okay, the boys ones are blue, the girls ones are pink, right? So this is the length or height for age for girls and for boys. What is the interpretation that we make out of this? If the length for age is less, length or height for age is less, what is the interpretation that we make? If it is stunting, isn't it? Stunting. So this is a symbol of chronic malnutrition. Chronic malnutrition. If it is between -2 and -3, then we say that this is stunting. No mild, no moderate. This is stunting. If it is below -3, then we say severe stunting. Okay, stunting, severe stunting. There is no mild stunting, no moderate stunting. Between -2 and -3 we say stunting, below -3 we say severe stunting. Okay, and this is a measure of chronic malnutrition. Clear? Going ahead, this is the next one, weight for age for girls and weight for age for boys. As you see, the color coding is same, just the axis have changed. There it was length or height, y-axis, here the y-axis is weight. So what do we look for this? From this we get a measure of acute malnutrition, isn't it? We get a measure of acute malnutrition. So acute malnutrition, what we say, what is the interpretation that we make? Again, between -2 and -3 we say that the child is underweight. Okay, -2 and -3 we say underweight. Below -3 we say child is severely underweight. Okay, again no mild, no moderate. Underweight, severely underweight. Clear? Going ahead, the third one, weight for length or height. Okay, please understand that this charting in this does not have any meaning till you have charted in the previous two. Okay, because suppose a child is chronically malnourished. Okay, the height is less, the weight is also less. So in this chart the child will come as normal, because this is not factoring in age. So first and foremost you have to do weight for age and height for age, because the growth is happening with respect to age. Once you have done that, we use this chart to look at severe acute malnutrition. Okay, we use this chart to look at wasting, what we call is wasting, whether there is an acute episode of malnourishment is happening. That is, what if the height of the child is normal, but the weight of the child is very less. That says that the child was apparently growing fine till when the child has had some problem in growth, and that's why it has faltered. Okay, so this chart, use it only after you have used the first two charts. Do not first thing you utter weight for height. No, first look in a weight for age, height for age, then look at this. Okay, so again, what is the interpretation? Between -2 and -3 it is wasting, below -3 it is severe wasting. Okay, severe wasting counts as severe acute Malnutrition, also known as SAM. Okay. So these are our growth charts, right? So these 6 growth charts, ensure that you are oriented to them, ensure that you know how to plot them, ensure that you know what is used for what, and they are all born out of the WHO Multicentre Growth Reference Study. Okay. So going back to our problem card. Okay. So this was the problem card, the same one we read first. So plot the weights on the growth chart and give your comments. Mention the important points the Anganwadi worker should discuss with Mithali. What is complementary feeding, isn't it? So plot the weight on the growth charts. What growth chart are we going to use here? We are going to use WHO growth reference standards, length or weight for age for girls birth to 5 years Z-score. Okay, that is what we are going to use. So if you are using that, before that what we need to remember here, that Mithali is already second gravida. She is in 8 weeks of gestation and her baby is 5-month old. Okay, so her baby is 5-month old and she is already in the 8th week of gestation again. Okay, the birth weight of the baby 2.75 kg, it is normal, isn't it? This is not low birth weight, this is normal, it is more than 2.5 kilograms. But then at 3 months the baby was at 4 kg, but at 4 months also the baby was at 4 kg. So for one entire month the baby has not had any appreciable increase in weight. Okay, that we can see from this only. Now let us go ahead and plot. So as you can see, I have plotted there. Okay, so just quickly I'll just zoom it on. Okay, so look, so first and foremost we plot the birth weight. Okay, birth weight is 2.75 kg. Okay, so what we do, birth is the origin. Okay, so we go up, this is 2, this is 3, so we plot it here, 3/4. Okay, we plot it here. How to plot? Put a dot where you want to plot and then put a circle around that. Okay, put a dot where you want to plot, put a circle around that. Remember, while plotting on the growth chart, we never plot in between the age lines. We do not plot in between the age lines. Suppose this is 2 completed months and this is 3 completed months. I have got a baby at 2 months 11 days. I will not plot it between 2 months and 3 months. No, I will plot it on the second month. Okay, we go by completed months. In the growth chart, we never plot in between the month lines. We never plot in between the month lines. Always go by the month lines while plotting on the growth chart. Is that clear? Do not plot by completed months at the time of your assessment, right? So look here, the baby was born on 19th March and here it has come on 25th of June. That means 3 months and 6 days. So where will I plot? I will plot on 3 completed months and the weight is 4 kg. So on 3 completed months, I have plotted the weight at 4 kg. Then again 4 months, 8 days, I will again plot on 4 months at 4 kg, isn't it? And then 5 months, 12, 13 days, I will plot it on 5 months, 5 completed months, 4.2 kilogram. So what you can see, and then what we have to do, we have to join the plots by straight lines. Do not carve when you draw. Join subsequent plots by straight lines. Is that clear? So how you will do, you will always plot on the month lines, not go in between the month lines, right? You will plot on the month lines based on completed months. You will plot by a dot and put a circle around that. Then you will connect subsequent dots by a straight line. Is that clear? That is how we plot. So this is the WHO chart that we have used, and as you can see in the WHO chart, what can you see? That the child began in the normal zone, isn't it? It was in between +2 and -2 at birth, but then at 3 months it has come on the -3 line, isn't it? It has come on the -3 line. Can you see? The black line is the -3 line. So at 3 months the child has come on the -3 line, and at 4 and 5 months the child has gone below the -3 line, right? So at 3 months the child was underweight. At 4 and 5 months the child has become severely underweight, right? So going ahead, is that clear with everyone so far how to plot? I do not want you making any mistakes if we ask you to plot therein during your exams, right? Clear with everyone? No doubts? Okay. So going ahead, we could have also plotted on the mother and child protection card. This is the growth chart that is present in the mother and child protection card. Unlike the WHO chart which just gives you lines, it gives you color coded. Okay. So see, this part is already marked as red. This part is yellow and this is green. Okay. Normal is green, underweight is yellow, severely underweight is red. Okay. So what we do, we can again plot like this. We can again plot like this. See, same thing, it was normal. Then the MCP card chart is slightly different from the WHO growth chart. Okay. Now see, there are some interpretations also given here. That what do we see from the growth chart? We do not just look at the points of individual plots. We also look at the trend. Okay. As the baby is growing in age, the trend should always be upwards. If there is flattening, that is also a problem. If there is a drop, then it's a serious problem. If there is a drop, then it's a serious problem. Okay. See, if it's flattening, it's dangerous. If it's going down, it's very dangerous. Okay. These are the interpretations simply that are given for the Anganwadi worker. Who will maintain the growth charts? The growth charts will be maintained at the Anganwadi center or at the ICDS center. When the child will be coming for immunization, when the child will be coming for monthly visits, then the growth charting should be done. Every monthly growth charting should be done according to programmatic guidelines. Okay. On the MCP card, there should be charting done for every month in the growth chart, ideally, right? And the responsibility lies with the Anganwadi worker to do it. Okay. It's the ASHA's job to mobilize, but it's the Anganwadi worker's job to do the growth charting at the ICDS center. At the ICDS center, all facilities for measuring the length and height and weight of the child are there, right? So how will we measure the weight of this child, height of this child? First of all, this child cannot stand. So we'll measure the length by the infantometer. Cannot stand. So no stadiometer, infantometer. Okay. And weight of this child again cannot stand. We'll use the Salter scale. Okay. We'll use the Salter scale. So what are our comments? We see that Usha gained only 1.25 kilograms in her first 3 months. The expected weight gain is at least 800 grams per month. So that means 2.4 kilograms. But she only gained 1.25 kg. And between the 3rd and 4th month, we have seen that there is a flattening. There is a growth stagnation between the 3rd and the 4th month. Okay. So this is a definite danger sign. Now, and the child by 5 months, the child has fallen into the red zone of severely underweight, isn't it? Now, what we are more concerned with here is that, see, the child was still growing till the 3rd month. Oh, I have made a mistake in plotting in this. Okay, I have plotted wrongly on the 4th month. Should have been on the 3rd month. Okay. So, but till the 3rd month, the child was still growing. Okay. But from the 3rd month onwards, the child has had a severe problem. The growth has stagnated, isn't it? Now, this stagnation, if you carefully observe, is coinciding with the pregnancy of the mother. Okay. So there are various cultural beliefs in our country which says that the moment a woman becomes pregnant again, the milk becomes bad. Okay. And due to that cultural practice, a pregnant woman does not breastfeed in various parts of our country. So this is a problem that we very often see. Okay. That is one of the important reasons why we want spacing as well. Okay. But the truth is that pregnancy has got nothing to do with breastfeeding. A pregnant lady can very well breastfeed her child. So we have to tell the mother here that breastfeeding has got nothing to do with your conception. We have to address the cultural taboos and see that she is breastfeeding the infant. So going ahead, trying to see what the Anganwadi worker should discuss with Mitali. First of all, why these growth charts are given in the MCP card? To show the mother. The mother, even if she is illiterate, she will be able to appreciate that my baby was in the green zone, went to the yellow and now has come to red. Okay, that visual seeing has an effect. Okay, it makes the mother, it makes it easier to convince the mother that something is wrong. Okay, and she starts to be involved in putting extra effort to try and correct the situation. Next, we re-establish exclusive breastfeeding. Okay, till 6 months, as we know, the child must get exclusive breastfeeding, and the fact that she is pregnant does not reduce her ability to breastfeed. She will still be able to breastfeed. So we must re-establish exclusive breastfeeding. Okay, so exclusive breastfeeding has to be started, and since it's her first child, she is second gravida now, it's her first child. So you need to look at positioning and attachment as well. Okay, because even before 3 months, the baby was not gaining adequate weight, isn't it? The baby was supposed to gain 2.4 kilograms, but it gained only 1.25 kilograms. So pregnancy might be a contributing factor here, but it is not the only factor. So you have to also assess on the positioning and attachment. Okay, so look at all of the interpretations that we are making from the growth chart. We are looking at the individual plots. We are looking at the initial growth. Even when it is upward, we are looking at whether it is sufficiently upward or not. Okay, and then we are looking at the trend where there is flattening, whether there is faltering, all of these things. Right. So with this one chart, we are almost having an entire assessment of the growth journey of this particular child, isn't it? Maternal care and nutrition. Okay, the mother now is both lactating and pregnant. So it is very, very important that she is taking the iron folic acid tablets. It is very, very important that she is taking the calcium tablets. Okay, that she is getting additional nutrition to be able to feed the child and feed the fetus growing inside. Okay, so we have to first register the pregnancy and ensure she visits the Anganwadi center to get the take home ration or the supplementary nutrition that she needs, right? Lastly, preparation for complementary feeding. The child is already at 5 months and 11 days. So within 19 days, the child will complete 6 months when we should start complementary feeding. Timely initiation of complementary feeding is at 6 months. So we have to counsel the mother, prepare the mother that how she will prepare the child, what kinds of food she can give to the child, at what consistency, at what frequency, at what amount. All these things need to be conveyed to the mother. Okay, so when you are asked what should Mitali talk, what should the Anganwadi worker talk with Mitali, remember all of these points that we have to talk about the growth. We have to see that pregnancy is not the only factor. Even before that, the child was not growing properly. So we have to look for positioning and attachment. We have to screen for whether there are any medical complications in the child. That every mother is doing everything correctly, but the child is not being able to grow because of some medical complication. Could happen. So we will refer the child to the primary health center to ensure that the child is evaluated at least once. Okay, and we will talk about getting the pregnancy registered as she is pregnant, and we will talk about complementary feeding. Is that clear? So going ahead, what is complementary feeding? Isn't it? So complementary feeding is the process that begins when breast milk alone is no longer sufficient to meet the nutritional requirements of the child, and we provide other foods and liquids from locally available cheap sources. Isn't it? So whatever is locally available and acceptable, from that we are starting to provide the child food, because breast milk alone is no longer sufficient to meet the nutritional requirements of the child. Isn't it? So what are the components? First of all, timely. It should be started, it should mandatorily be started at 6 months. Okay. You know what is the ritual that we have? Annoprashan, isn't it? Now there are many parts of this country where annoprashan for male children is done at 6 months, but for female children it is done at 5 or 7, more often in 7. Okay, so the problem with that is complementary feeding gets delayed by 1 month. Okay, so you have to tell the mother that when the child is a child, there is no gender difference. Okay, both of them require complementary feeding to be started at 6 months. Okay, so under the Poshan Abhiyan, under the national programs also, you know, the community often comes together and celebrates Annaprashan in the villages, be it for the girl child, be it for the boy child, and at 6 months. Okay, timely initiation of complementary feeding at 6 months. Next, adequate. Okay, what should be the amount? So if you look at the MCP card, we'll look, the amount is specifically mentioned that, okay, we'll begin with how many spoons, and then how much of the katori, how many times, frequency, how many times. So amount at each feed and frequency. You cannot force feed the infant. The infant has a very small stomach. You cannot force things down its throat. It will vomit it out. Okay, so food has to be given in small quantities at repeated intervals, isn't it? So what frequency to begin with, what frequency to target, how much amount, all of these things should be talked about. Next, to make it adequate, frequency alone is not enough. What is more important is the consistency, because since the stomach size is small, if we make the food runny, what will happen? Majority of it will be water, and water provides no nutrition here. The breast milk is sufficient to provide all the water that the child needs. Okay, so the food that we are feeding the child has to be thick, but for it to be too thick, then the child will not be able to gulp it down. Okay, so it has to be, what we say in our program is, it has to be thick, soft in consistency. So how to explain to the mother thick, soft? So what we say is, once you prepare the meal should be such that if you pick it up with a spoon and put it in slanting, then it will go ahead on the spoon but not fall down. Okay, so once you prepare the meal and you pick it up with a spoon and you hold it in a slanting angle, then the food goes ahead on the spoon but it does not fall. That is the ideal consistency for the food to be given to the child. So to make it adequate, we must look at three things: the amount, the frequency, and the consistency. Clear? Next, safe, hygiene. See, till now the baby was only getting mother processed food. This is for the first time that the baby is getting exposed to the bacteria, to the pathogens. Some of them are commensals, but many of them are pathogenic. Okay, and the baby's gut lining is still not entirely prepared to deal with all of the pathogens. So a lot of emphasis has to be given on the hygiene of the preparation. Okay, how to prepare the foods in a very hygienic way. Before preparation of food and before feeding the food, the mother needs to wash her hands with soap and water. Going ahead, the mother must also wash the hands of the child with soap and water before feeding, because during the process of feeding, the child invariably puts its fingers and hands into its mouth. Okay, the child in this period is in the anal phase, is in the oral phase, where it puts everything into its mouth. So we need to take care to wash the hands of the child as well, not just the hands of the mother or the caregiver. Lastly, responsive feeding. You cannot put a mobile phone in front of the child and force feed it. That is not done. The child will not be able to understand how much it is eating. You will not be able to understand how much the child requires. Okay, so the process of responsive feeding. Feeding is a time when there is bonding between the mother and the child. How the relationship between the child and the mother and parents will be going ahead will be determined by responsive feeding. Okay, so the child should be involved in the process of feeding. Going ahead, we will also ask the mother to cut some finger foods, maybe some chiku, some mango. She will cut and put it in a bowl in front of the child. While the mother feeds, the child will also start picking up and putting it to the mouth. So the child is involved in the process of feeding. What it does, till the child is doing that, you understand that the child is still hungry. Once the child is not doing that or pushing it apart, you understand that the child is fed. We should not force feed children. Okay, they cannot speak, they cannot express. That does not mean it's almost like a torture. Okay, just putting spoon after spoon. Okay, just to expect a lot of growth. It's not required. They have a small stomach. They will regurgitate. Okay. So, as we remember, timely, adequate, safe, and responsive feeding. Okay, responsive feeding can come as a short note. It's a very, very important thing. Just understand the concept, rest you can write. Okay, this entire process of involving the child with the mother in the process of feeding is known as responsive feeding. Okay, all of these things are mentioned in the MCP card. Okay, just go through the MCP card. I have also brought the screenshots of the MCP card in case you do not download it. Okay, so spoon feeding to you, not responsive feeding so far. Responsive feeding will begin when you download the MCP card. Okay, so see, everything is written on 6 months, what to give, what frequency, what kind of food, what consistency, how much. Everything is mentioned. I will not go into the detail, I do not have the time. So 6 months, 6 to 9 months, 9 to 12 months, and general tips of preparation. See, everything is written there. Okay, so you need not need to read Nelson or Ghai for coming to the IYCF exam of community medicine. Just read the MCP card, understand that much. Okay, understand what is written there. This is not written for doctors. This is written for Anganwadi workers to explain to mothers and for families to read themselves, for the families who can read. So this is not something hi-fi. You can just read it and understand. It is very, very important. Practical, simple things which help the family. Okay. So this is all that we had to discuss till now. So looking again at the problem card, we have finished discussing this. Okay, you understand how to plot on a growth chart, you understand how to interpret, and you know what is complementary feeding, isn't it? How much time do I have? Okay, so I have 10 more minutes. Okay. So problem card 2. Problem card 2. So Mahi, daughter of Manas and Devika, was born on 6th August 2025. Birth weight was 2.5 kg. Subsequent weights of the child at different ages. So at 3 months, child was at 5 kg. Then at 6 months, child is at 6.2 kg. And at 8 months, the child is again at 6.2 kg. Okay, so it's slightly different from the initial scenario. What we want to do, again plot the weights on the growth chart. What feeding advice will you give to the mother? So again, let us look. See, the birth weight was borderline. Okay, it's not low birth weight. It's 2.5 kg, so it's not low birth weight. It's borderline. Then the child, for the initial 3 months, the child has grown all right, isn't it? Then at 6 months, the child has not grown entirely okay. But from 6 to 8 months, the child has not grown at all. So what is this time? This is the time of initiation of complementary feeding. So we understand from the timing that the problem here is not with breastfeeding probably, but with complementary feeding, isn't it? The problem here is probably with complementary feeding, right? So going ahead again, we have plotted. Okay, I'll zoom it again. So you can see at birth, the child is okay. At 3 months, the child is again okay. At 6 months also, the child is okay. But at 8 months, the child has fallen into moderate, it has fallen into underweight, isn't it? It has fallen into underweight, right? So again you can see here. So what we can appreciate here is flattening. Okay, we call this as faltering. This is known as growth faltering. Growth that was initially occurring fine, but then it falters. Okay, it falters. Why it falters? It falters probably because complementary feeding is not proper. It falters probably because once you start complementary feeding, if the preparation is not proper, the child starts getting infections. Okay, so that is one of the main causes of growth faltering between 6 months and 12 months. It's a very, very vital period for children's growth journey. Okay, so let us again look at the problem card once. The child is breastfed and occasionally takes rice with family members. Now, what should be the complementary feeding? It is very fixed. What kind of food, what frequency? So, occasional rice is not sufficient, isn't it? We'll again go back and look at this. See, the child at 6 months, what is the advice? On completion of 6 months, start feeding baby with 2 to 3 tablespoons of soft, well-mashed foods 2 to 3 times a day. So no question of occasional feeding. Okay, at least 2 times, preferably 3 times, given thick soft consistency mashed foods. Okay, and not just rice, introduce one food at a time, such as a small amount of vegetables followed by fruits, dal, cereals, and then animal foods as well where it is culturally acceptable. Okay, next, increase the amount of feed slowly. Give iron drops, iron syrup. As we know, from 6 months onwards we must give iron drops, IFA drops to the children weekly, isn't it? So going ahead, so we can see that this has come into dangerous. The plot is not in the dangerous zone, but the trend on the plot is dangerous. Okay. So for 2 months the child has lost growth, 2 months. So comments, we have seen a normal early growth, followed by that we have seen a growth faltering or stagnation, okay, between 6 months and 8 months. The stagnation coincides exactly with the age when complementary feeding should have been started. So history states child occasionally takes rice, which means complementary feeding is grossly inadequate in quantity, frequency and quality. The caloric and protein gap is causing the child to become moderately malnourished, okay, and the child is underweight. So what is the advice? The advice is you continue breastfeeding, then you put a lot of effort on complementary feeding. See, occasional rice is not sufficient. At 8 months, Mahi must be given solid semi-solid food at least 3 times a day, and the amount should be half a cup of a standard katori at each meal. Now what to give in the food? Rice alone is not sufficient, preferably khichdi, where with rice you put dal, and with dal you also put some vegetables, one vegetable at a time, and the vegetable should be properly cut into small pieces, okay. Next, you can also introduce eggs and meat if it is culturally acceptable, and mashed fruits as well you can give. No need to boil fruits, okay, fruits can be given like that only, but they need to be mashed, okay, because the child has still not developed all of its teeth, okay. Next, and you add a spoonful of oil, ghee or butter, very very important. You do not add oil to the cooking of foods of children, okay. You add raw oil, ghee or butter before giving the food. What it makes the food energy dense. We know for the same amount, giving oils and fats gives you much more calorie. So to address the calorie, because this is again a child who is not growing, so it has not grown, its stomach has also not grown, its stomach is also small. So you have to give the additional demands of 8 months in a stomach that is 6 months of size, okay. So you have to add some food, so you put some ghee, butter and oil, okay. Always remember, till 1 year in children's food, no salt or sugar should be added. No salt or sugar should be added to a children's food, complementary food, till 1 year, okay. Only after 1 year, when the child starts eating from the family pot, will we add salt or sugar, right. Then the other things that we have already said, practice hygiene and practice responsive feeding, okay. Next, follow up, what we will do, so we will, since the child has fallen into underweight, we will follow up after 15 days. Ideally, we follow up at monthly intervals, but since the child is gone into malnutrition, we'll follow up after 15 days, okay. The child is in underweight, it is not severely underweight, so there is no need of facility based management here, okay. So this is another problem card for you to go through later on, it's similar, so I have not discussed it. So now we come to severe acute malnutrition quickly. How much time do I have? I have 6 minutes, okay. So I'll quickly go through this. Severe acute malnutrition, so how we classify it? We use 3 things in the criteria. First, we look at the weight for height, okay, the weight for height, that chart, the third chart. We first do the weight for age, height for age. If there is problem in either, then we go to the weight for height, okay. Once we come to the weight for height, if the child is below the -3 SD, that is wasting, that is one of the criteria for severe acute malnutrition, okay. Or if that is not there, if there is mid upper arm circumference, if it is less than 11.5 centimeter, that is also SAM. How we measure? We measure it with a Shakir step. Shakir step. We measure it, not Shakira. Some of you in the exam you have written Shakira. Okay, it's Shakir step. Shakir step. This is what happens when you copy. Okay, it's Shakir step. You measure. It has to be less than 11.5 centimeter. Okay, not. This is the first time I have got such a warm response. Okay. So, weight for height less than -3 SD or mid upper arm circumference less than 11.5, or if there is any nutritional edema. Nutritional edema in children we look at as pitting edema in the feet. So, if there is bilateral pitting edema in the feet, that is a danger telltale sign of SAM. Okay. उसके बाद वो जो abdominal ascites जो आता है वो बाद में आता है. First it begins from the, this is a dependent edema, so it begins in the feet. Okay. So any of these three classifies as SAM. Okay. If a child is having any of these three, the child is classified as SAM. If a child is having SAM and along with that the child is having any medical complication, then we have to admit the child to a nutritional rehabilitation center, okay, for facility based management of childhood malnutrition. Okay. So nutritional rehabilitation, what it does, it is practical training. Training is given. Only the child is not admitted, the child is admitted along with the mother. So we give practical training to the mother on how to, so practical training to mothers of children with malnutrition in selecting and preparing food from locally available cheap sources and feeding them back to the health. So the mother will be trained how to, what food to eat, how to prepare, what to prepare, how to feed, how to maintain hygiene, and most importantly responsive feeding. All of this training is given during nutritional rehabilitation. It is not just feeding the child back to health, okay. It is addressing it from a systems aspect to see that once the child goes back to the community, the child does not again fall back into malnutrition. Malnutrition always does not happen due to an infection. Mostly it happens due to problems with the process of feeding. So the process of feeding has to be taken care of, and that is the objective of nutritional rehabilitation. So quickly look at what are the objectives: clinical management and reducing mortality. So if there are any medical, I said that NRC we admit only if the child is having SAM along with medical complications. So first objective is to ensure clinical management and reduce mortality. We do not want under 5 deaths. Next, to promote physical and psychosocial growth of the child. Next, to build the capacity of the mothers to be able to maintain that. And lastly, to identify social factors. Okay, it's a girl child, feed is not being given from the family. Okay, the mother has become pregnant again, family is not allowing her to breastfeed. Okay, there is another boy child, the family is asking the mother to concentrate more on the birth. There can be various social factors that are associated with childhood malnutrition. Nutritional rehabilitation is for that aspect also. You get the mother and the child in your facility for 10-15 days to talk to her, explore the reasons and try and address them, right? So nutritional rehabilitation center, it's a health facility where it is done. It has a defined admission criteria with medical and nutritional care where we provide them. Okay, so quickly going on, what are the services? 24 hours care, treatment of medical complications, therapeutic feeding, sensory stimulation and emotional care, as I was telling you, responsive feeding. Okay, next, social assessment of the family to identify and address contributing factors, counseling on appropriate feeding care and hygiene, demonstration of the practice. The mother is involved in the process of cooking food for the children at the NRC. Okay, and finally follow up of children discharged from the facility. So I have added all of that. What is the admission criteria? So as you can see, the admission criteria is same as that for classifying children as SAM. Okay, next, along with that you have to have some medical complications for children to be admitted to the NRC. Okay, this is for children who are 6 to 59 months old. If children are less than 6 months old, then any of the classification of SAM along with lethargy or refusal to feed counts as the medical complication. Small children do not show all of the signs and symptoms that older children show. So lethargy or refusal to feed is enough along with any of the criteria for SAM, and we admit the child. Once we admit the child goes through 3 phases. First is stabilization, next is transition, and finally there is rehabilitation. Objective of stabilization phase is to cure the medical complication. Whatever medical problem has occurred, we want to treat that. Okay, and the child at this time, there can be some problems with giving it a lot of feed all of a sudden. Okay, the child is not able to tolerate. It is known as refeeding syndrome. Read about it once you go home. What is refeeding syndrome? So to be careful about refeeding syndrome, we give the child small diet, F75 starter diet in stabilization phase. As we go ahead in transition phase, we give it the actual nutrition for it to recover its growth. So that is the F100 diet, the diet that we are giving to nourish the child back to health. Okay. Once the child moves on into rehabilitation phase, this is the phase where we want to promote rapid gain, weight gain, stimulate emotional and physical development, and prepare the child for discharge and going back into the community and growing normally. Okay. So I could not discuss this in detail because of paucity of time. So you read it. Then discharge criteria. As we are admitting both the mother and the child, the discharge criteria is not just based on the child but also on the mother. Okay. So there are some achievables to be achieved for the child and for the mother before we are going to discharge the child from the nutritional rehabilitation center. Okay. So read them, go through it, and then follow up. There is a follow up algorithm also for how to monitor. The child have been discharged, but they came not just because of a one-time problem that you give antibiotics, cure and go away. There was a systemic problem. Okay. So they need to be in follow-up to check whether the systemic problem has really been addressed or not. Because once a child falls into malnutrition, it has a tendency of going back into malnutrition every once it suffers a illness or something. Okay. So the child needs to be in follow-up. So the follow-up is very, very essential for nutritional rehabilitation. The NRC maps the child to community-based rehabilitation available from the ICDS centers or from the primary health centers. Okay. So that is what all we had to discuss today. Okay. So we have understood how growth charts were developed, how to plot on growth charts. Growth charts, typically you have two growth charts. You have the MCP card and you have the WHO growth charts. Both are based on the same growth reference standards, the WHO growth reference standards from the MGRS study. Okay. Just the color coding in the two charts is different. In one chart you only have the lines, in the other chart you have the classification of green, yellow and red. Okay. The interpretation is underweight, severe underweight, stunting, severe stunting, wasting, severe wasting. Severe wasting counts as SAM. We have told you need of exclusive breastfeeding, complementary feeding, responsive feeding. SAM, how to classify children as SAM, what is nutritional rehabilitation, what are NRCs, when to admit child to NRCs, how to manage child through stabilization, transition and rehabilitation, what is discharge criteria, what is follow-up criteria. Okay. All of this is present in this PPT. You can read it from there. I'll circulate it to you. What is important for you to go and read, if you are interested, read refeeding syndrome and also do download the mother and child protection card. Okay. Download it and go through it. It's very, very important. Okay. You'll understand what is actually done on the field. Okay. Without it, it's very, very difficult to understand. Go through the chart from first page to last page. Look at all the data that we take, what we plot, what we do on subsequent visits. Everything is given there. Okay. So thank you. If you have any questions.